Hey everyone, and welcome. Today, we're taking a high-yield tour of female pelvic anatomy. So, the goal here isn't just to memorize a bunch of facts, but to build a really solid clinical framework that makes your revision stick. You know that feeling when you're studying and it just feels like a list of disconnected names and structures? Well, if that's you, you're in the right place. We're going to move past that today by building a clear clinical map of the pelvis, linking every structure directly to its function, and you guessed it, its pathology. All right, let's dive right in. We're going to start from the outside and work our way in. Our first stop is the external genitalia, also known as the vulva, where you'll see that even the smallest details have some big clinical importance. So here's the big picture. As you can see, the vulva is framed by the mons pubis at the front and extends all the way back to the perineum. We're going to be zeroing in on the key structures right here in this area. You know, the labia, the clitoris, and the vestibule, which is home to the urethral and vaginal openings. Now let's zoom in on the labia. Here's a super important distinction, especially for your exams. What's inside them? The outer folds, the labia majora, are filled with fatty tissue and have hair follicles, which makes them the homologue to the scrotum. But the inner labia minora, totally different. They have no fat, no hair, and they're homologous to the ventral side of the penis. And here is exactly why that little anatomical detail matters so much. The labia majora are absolutely packed with a rich network of veins. This means that an injury here, which happens a lot during childbirth, can lead to a really big and very painful hematoma. It's just a perfect example of how structure directly dictates pathology. Okay, now tucked away deep in the superficial perineal pouch, we find the Bartholin's glands. They're tiny, about the size of a pea, but their job is vital. They secrete an alkaline mucus that provides lubrication during sexual arousal. The most important part here isn't the gland itself, but its duct. Each gland has this little 2-centimeter duct that opens up into the vestibule. So what happens if this duct gets blocked? Well, all that mucus has nowhere to go. It backs up, forms a painful cyst, and that cyst can easily get infected and turn into an abscess, a classic clinical problem tied directly to this tiny piece of anatomy. All right, moving inward, we come to the vagina. Now, it's easy to think of it as just a simple passage, right? But it is so much more than that. It's actually an incredibly dynamic, physiologically active organ, and we're about to see how. Okay, this diagram gives us a great look at some key features. Notice how the walls aren't the same length. The anterior or front wall is a bit shorter, around 7 centimeters, while the posterior wall is longer at 9 centimeters. And check out the cross-section. See how the walls are normally collapsed against each other? That gives the vagina its classic H shape. Let's really focus on the fornices for a second. Those little pockets at the very top of the vagina. These aren't just empty spaces, you guys. They are critical surgical landmarks. The posterior fornix, the one in the back, is the deepest, and it's your direct access route to the pouch of Douglas. But pay close attention to the lateral fornices. They are alarmingly close, only about 2 centimeters away from the ureters and uterine arteries. Knowing these relationships is absolutely vital for any kind of pelvic surgery. I love this analogy because it explains the vagina's physiology so perfectly. Just think of it as a protected garden. When estrogen is around, the vaginal lining becomes rich in glycogen. This glycogen is basically food for the good guy bacteria, Doderlein's bacillus. And what do? They eat the glycogen and produce lactic acid. This whole process creates an acidic environment that acts like a natural defense system, preventing pathogenic weeds from growing. And this table just pulls that whole concept together beautifully. Just look at the pattern here. During the reproductive years, you have high estrogen, which means you have glycogen, an acidic pH, and lots of those protective Doderlein's bacilli. But before puberty and after menopause, when estrogen is low, the whole system just flips. The environment becomes alkaline, and that protective flora vanishes. It's a complete hormonal story, all right here. Okay, let's keep moving up now to the uterus. And we're going to explore its really important relationship with the peritoneum. This interaction creates some of the most clinically important spaces in the entire body. So let's break down the uterus. You've got the fundus up top, the main body or corpus in the middle, and the cervix down below. A really key detail to notice is the isthmus. It's this little transitional zone that contains the anatomical internal os and, just a bit below it, the histological internal os. Now, to understand the peritoneum, just picture a sheet being draped over all the pelvic organs from front to back. In this view, you can trace it. See how it covers the bladder, then reflects up and over the uterus, and then drops down behind it to cover the rectum? It's these folds, these reflections, that create those super important pelvic pouches. And the most important one of these is the pouch of Douglas, also called the rectouterine pouch. Its clinical significance is huge. Why? Because it is the most dependent or lowest point of the entire peritoneal cavity when a person is standing up. So think about it. Any free fluid in the abdomen, blood, pus, acidic fluid, is going to pool here first. That makes it a huge diagnostic clue. All right, that brings us to our final section. Let's switch gears and do a rapid-fire recap of the most testable, high-yield concepts we've covered. This is the stuff we need to lock in. You're going to see this on exams for sure, so let's run through them really quickly. Remember, labia majora corresponds to the scrotum. The labia minor, that's the ventral aspect of the penis. The clitoris is the penis itself. The Bartholin's glands are homologous to the bulbourethral glands. And finally, the ovarian and round ligaments together correspond to the gubernaculum testis. Got it? Okay, burn these 4 crucial relationships into your memory. Number 1, water under the bridge. The uterine artery always crosses over the ureter. 2, the posterior vaginal fornix is your clinical gateway, your secret passage to the pouch of Douglas. 3, the ureters are just hanging out about 2 centimeters away from the lateral fornices. And 4, the fourchette is the most common site of perineal injury during childbirth. This quote from Dada really brings it all back to the beginning. It's so important. If you understand that the Mullerian ducts are the foundational blueprint for the uterus, the fallopian tubes, and the upper vagina, you've got the master key. This single concept explains not just normal anatomy, but also the entire spectrum of congenital anomalies. And that brings us to our final thought. I'll leave you with this question to think about. Knowing that the uterus forms from the fusion of 2 Mullerian ducts, how can you use that single principle to predict the different types of congenital uterine anomalies that happen when that fusion process is incomplete? Give it some thought. It's a great way to tie all this knowledge together. Thanks so much for watching.